Hi, my name is Lucas Kellerbiehl. I'm a PGY3 general surgery resident at Virginia Commonwealth University and our affiliate, Central Virginia VA in Richmond, Virginia. And I will be presenting our project, Comparison of Short-Term Surgical Outcomes of Colectomies by Race within the VA System. We have nothing to disclose, and the contents of this presentation do not represent the views of the U.S. Department of Veterans Affairs nor the United States government. So racial disparities in healthcare access and outcomes between races is well documented in the literature. Some root causes that have been postulated include intrinsic to the healthcare system, such as trust in the system, screening rates, preventative medicine, and provider bias. Extrinsic factors to the hospital include social support, health insurance, unemployment rates, and education. Veterans have greater access to healthcare and other social benefits, which may mitigate social determinants of health and therefore decrease healthcare disparities between the veterans of different races. So therefore, we hypothesize that differences in postoperative outcomes after colectomy would be similar across racial groups within the VA. So we conducted a retrospective study analyzing the Veterans Affairs Surgical Quality Improvement Project, looking at colectomies conducted between 1999 and 2019. Demographics, comorbidities, and 30-day postoperative outcomes were evaluated by race via chi-square and ANOVA testing, and we used an alpha of 0.001 as a cutoff for statistical significance. So this, looking at the demographics, as expected, veterans are overwhelmingly male, ranging between 93 to 95% or 97%. Across the racial groups, white patients were the majority of the veterans, being 75.7%, followed by black patients at 17.6%, Hispanics at 5.7%, and then Native American at 0.7%, and Asian and Pacific Islanders at 0.3%. 14% of our cohort didn't have a listed race, so that they were excluded. So there were statistical differences between comorbidities across the racial groups. As you can see, heart disease was highest in white and Native Americans, and black patients had the lowest, at least recorded rate within the VASQUIP database. And then white patients had the highest rates of COPD of the racial groups. In contrast, white patients had the lowest rates of end-stage renal disease requiring dialysis, diabetes, and hypertension. But overall, 30-day outcomes were not statistically significant, looking at any complication or postoperative mortality, despite the differences in the comorbidities. But looking at specific complications, the only two that were statistically different across the racial groups were postoperative AKI, which African Americans and Native Americans were the highest in that group, which at least for the black cohort, they had higher rates of diabetes and hypertension and underlying renal disease, which likely would explain that. It's a little bit harder to explain the differences in postoperative cardiac arrest, given that black patients had lower rates of at least documented cardiac disease, especially compared to white patients. However, given that they did have higher rates of hypertension, diabetes, and risk factors for cardiac disease, this would suggest either an underdiagnosis of black and also Hispanic patients, and potentially lower preoperative cardiac optimization. So the limitations in this study were not able to address or analyze disparities in screening, prompt diagnosis, and equivalent care leading up to surgery. And then disparities in surgical outcomes may not be apparent within the 30-day postoperative window, and just the inherent limitations of a retrospective study. So in conclusion, 30-day morbidity and mortality between white and minority patients within the VA system were non-significant after colorectal surgery. Rates of postoperative AKI and cardiac arrest were different between the groups and potentially explained by higher rates of certain comorbidities or underdiagnosis of cardiac disease in those groups. And then future work is required to elucidate other potential disparities before surgical consultation and outcomes beyond the 30-day postoperative period, both inside and outside the VA system. And we got a lot of references here, and then questions.
Thank you.
Yep.